Hey guys, my name is Akshi and today I'm going to discuss the topic 𝙤𝙘, which is also known as acute necrotizing ulcerative gingivitis. Now it is one of the most important topic under the periodontology department, and basically it is asked in the MUHS university examination for about 10 marks. So without any further delay, let's proceed. First, I would like to discuss about the definition of 𝙤𝙘 and then I will cover the topic under the following different headings. So first, what is 𝙤𝙘? It is a specific and a clinical entity which leads to severe periodontal disease. It leads to acute periodontal destruction. It is a rapidly progressive ulcerative disease. It has a rapid onset and it is very painful. So first, when we discuss about the definition of 𝙤𝙘, so first we can say that it is a specific and a clinical entity. Second is it leads to severe periodontal disease. Third is it leads to acute periodontal destruction. Fourth, it is a rapidly progressive ulcerative disease. Last, it has a rapid onset and it is very painful. Also, we can add one more, that it basically starts at the tip of the interdental papilla and then it commences and also includes the marginal gingiva, the attached gingiva, and sometimes it may also involve the bone. So I would just add a point over here, that is, it begins at tip of interdental papilla. Involving marginal gingiva and the bone. So it begins at the tip of the interdental papilla involving the marginal gingiva and the bone. You can take a picture of it. Now next we are going to discuss about the etiology of the 𝙤𝙘. Now 𝙤𝙘 is basically caused by the fusospirochetal complex. Now you must be wondering what comes under the fusospirochetal complex. So the organisms which comes under the fusospirochetal complex includes, first is the Fusobacterium nucleatum. Fusobacterium nucleatum is the most important organism, which is the most important causative microorganism of 𝙤𝙘. Next is the spirochetes. Third, Borrelia vincenti. Vibrios. So this all are the organisms which leads to 𝙤𝙘. Fusobacterium nucleatum, spirochetes, Borrelia vincenti and Vibrios. Now all these organisms, they are gram-negative, they are anaerobic microorganisms, and they are rod shaped and facultative anaerobes. So this is the etiology of the 𝙤𝙘. And often all these microorganisms, they are present in our oral cavity also, and basically they live in an environment where there is complete absence of oxygen. Now, what are the different types of the reasons that may lead to the multiplication of this species? So it is the poor oral hygiene, the accumulation of the plaque and the calculus, gingival injury, smoking, or any kind of other periodontal diseases. So by this we complete the etiology of the enoch. Now let's proceed to the factors leading to enoch, that is acute necrotizing ulcerative gingivitis. Now there are so many factors. Now the first factor is the local predisposing factors. The local predisposing factors include: first, injury to the gingiva. Injury to the gingiva includes traumatic injuries which are caused to the gingiva, like gingival laceration, etc. Second, it includes the pre-existing gingivitis. Pre-existing gingivitis involve the presence of deep periodontal pockets and often pericoronal flaps. They create an environment where this fusus pyrochetal complex involving the facultative anaerobes, those gram-negative rod-shaped microorganisms, they get a very favorable environment to multiply, and which often leads to enoch. Next is smoking. So smoking is also one of the most important causative factor of enoch. Now second comes the systemic factors. Systemic factors involve the presence of nutritional deficiencies, nutritional deficiencies involve the deficiency of vitamin B and vitamin C mostly. Second is the debilitating diseases. Which involve metallic intoxication, gastrointestinal diseases, blood disorders involving anemia, AIDS, and leukemia. So these are the factors which are leading to enoch. Local predisposing factors, which is injury to gingiva, pre-existing gingivitis, smoking. Systemic factors involving nutritional deficiencies like deficiency of vitamin B and vitamin C, and debilitating diseases involving metallic intoxication, gastrointestinal diseases, blood disorders including anemia, AIDS, and leukemia. Now the next factor, the last, is the psychosomatic factors, which involve that now whenever any person takes stress, then what happens? Due to the negative impact which is created inside our body, inside our brain, this leads to increase in the levels of serum cortisol, and which then often leads to the activation of HPA axis. What is HPA axis? It is the hypothalamic pituitary adrenal axis. Now, when the HPA axis is activated, then it leads to depression of lymphocytes and the PMN, that is the polymorphonuclear lymphocytes. Now let's discuss about the signs and symptoms of 𝙔𝙘. It includes intraoral signs and symptoms, and extraoral signs and symptoms. Now let's discuss about the intraoral signs and symptoms. Intraoral signs and symptoms include: there is seen a punched out crater-like depression seen on the tip of interdental papilla, marginal gingiva. So, a punched out crater-like depression is seen on the tip of the interdental papilla and including the marginal gingiva. A pseudomembranous slough, or we can say there is a pseudomembranous covering which is seen over the ulcerations. That ulcerations are covered by a pseudomembranous slough that is grayish in color, and it often leads to deep ulcerations and necrosis of the gingiva. So these are the intraoral signs. Now let's discuss about what are the intraoral symptoms. The intraoral symptoms includes there is fetid smell, increased salivation, radiating pain, gingival bleeding, the lesions are often sensitive to touch, and the pain intensifies on consuming hot and spicy foodstuffs. So these are the intraoral symptoms. Now let's discuss about the extraoral symptoms, which includes loss of appetite, lymphadenopathy, fever, increase in leukocytes, Now let's discuss about the histopathological features of the 𝙤𝙀, which includes changes in the epithelium as well as the connective tissue. Now, what are the changes in the epithelium? So the epithelium is completely replaced by an ulcerated layer of epithelium, and which is covered by a pseudomembranous grayish slough, and the entire surface is surrounded, or the entire surface is just covered with a grayish membrane. Connective tissue, the changes which are occurring in the connective tissue involves the engorging capillaries and the dense inflammatory cell infiltration. Now let's discuss about the diagnosis of the 𝙤𝙀. Now the diagnosis of the 𝙤𝙀, which we are going to talk, it just involves taking a biopsy, that is a live tissue is taken from an individual, and then it is examined for further pathological diseases, which involves differentiating it from the diseases or disorders like tuberculosis and etc. So biopsy is most important, or any kind of neoplastic disorders also we can diagnose by the help of the biopsy. Now next we are going to discuss about what is the differential diagnosis. It involves pemphigus and streptococcal gingivitis. So these are the histopathological features in changes in the epithelium and the connective tissue, which I have already discussed. Diagnosis is done by biopsy. Differential diagnosis, pemphigus, streptococcal gingivitis. Also syphilitic gingivitis we can add. Now we'll discuss about the treatment plan of 𝙤𝙀, which I will describe under the following heads, that is first visit, the second visit and the third visit. So first, in the first visit, we need to take the thorough history. We need to do the clinical examination. We need to take the dietary history, the medical history, the history of the smoking, history of any kind of underlying disorders the patient may have, the genetic, the inherited disorders. And then later on, once the medical examination is done, we need to clean the area or the pseudomembranous grayish slough, or the membrane, the grayish membrane, with the help of a moist cotton swab, and we can apply a topical anesthetic agent over there. Generally supragingival scaling is advised, but we need to avoid the subgingival scaling and curettage, as it may lead to the bacteremia. So in the first visit also we can prescribe the antibiotics to prevent the further infection, generally which includes amoxicillin 500 mg every 6 hourly. If the patient is allergic to amoxicillin, we can give erythromycin, same dose, that is 500 mg every 6 hourly. Otherwise, metronidazole can be given 500 mg twice daily for 1 week. We can also prescribe NSAIDs, non-steroidal anti-inflammatory drugs. So this all is done in the first visit. And the patient is also given further instructions to avoid consumption of alcohol, tobacco, even to rinse his mouth with chlorhexidine mouthwash 0.12% twice a day, and with also to replace chlorhexidine mouthwash, hydrogen peroxide 3% along with warm water every 2 hourly. Gargles can be done, and all protective measures are also taken, and in order to reduce the severity of the 𝙤𝙀. Now second visit is basically 1 to 2 days after the first visit. Generally erythema can be seen, but the necrotic tissue is quite decreased during the second visit. We need to observe the symptoms of the patient, that its severity has become less or not, but the lesional area will be erythematous, but the symptoms will slowly resolve, and the amount of the necrotic tissue might decrease during the second visit. Now the third visit is 5 days after the second visit. During this time, supragingival scaling, even the root planning can be done. The patient is now asked to discontinue the hydrogen peroxide, and the patient can now continue with the chlorhexidine mouthwash for the next 2 to 3 weeks. Counseling of the patient should be done to quit the habit of smoking, tobacco chewing, alcohol consumption, and also several measures should be taken. Several surgeries should be done in order to prevent the chronic periodontal diseases. And after 1 month, the patient is called for the maintenance therapy to re-evaluate the gingivitis, the gingival conditions, the plaque, the calculus, the periodontal tissue. Now, some of the additional treatment plan is also there, which involves first reshaping or contouring of the gingiva, which is basically a surgical procedure which is done by periodontal plastic surgery, in which we reshape the margins of the gingiva to create the normal physiological gingival contours. And next is the nutritional supplements like vitamin B and vitamin C can be given. So by this we complete the entire topic of the 𝙤𝙑, which is basically asked for 10 marks. I have discussed it under the following subheadings. So for 10 marks, this answer is quite sufficient. Thank you.